Every morning and every evening, at roughly the same time, you do something small and consistent. You take your metformin. You have been doing it exactly as prescribed for months, perhaps for years. You have not missed doses. You have followed the instructions about taking it with food to avoid stomach upset. You have done everything that was asked of you. And yet when you check your fasting glucose, or when your doctor calls with your latest HbA1c result, the number is better than it was before you started medication. But it has not reached the target your doctor has been hoping for, or it improved initially and then plateaued, sitting stubbornly at a level that medication alone does not seem to be moving any further. If that is your experience, I want to tell you something clearly before we go any further, because I have had this exact conversation with more patients than I can count. You have not failed. Your adherence has not been the problem. What has been missing is an understanding of precisely what metformin does inside your body, and just as importantly, what it was never designed to do. Once you understand that distinction, the plateau you have been experiencing will make complete sense, and you will know exactly what to add alongside your medication to move past it. My name is Dr. Sarah Monroe. I spent 12 years in internal medicine, and metformin is one of the medications I prescribed and discussed more than almost any other, because it is a foundation of treatment for the overwhelming majority of people with type 2 diabetes worldwide. It is effective, it is safe for the vast majority of patients, and it remains a first-line treatment for very good reason. But in every single conversation I had with a patient whose numbers had plateaued despite consistent metformin use, the missing piece was never about the medication failing. It was about 3 specific biological processes that metformin simply does not target, continuing to drive blood sugar elevation regardless of how faithfully the prescription was followed. Today I am going to walk you through exactly what metformin does at a cellular level, the 3 processes it does not address that are very likely responsible for your plateau, and precisely what the research supports adding alongside your medication to move your numbers further than metformin alone is capable of doing. As always, nothing in this video suggests altering your medication or your dose without your doctor's involvement. This is about understanding your treatment completely, not replacing it. Let us start with what metformin actually does, because very few patients have ever had this explained beyond it helps control your blood sugar. Metformin's primary mechanism of action is a suppression of hepatic gluconeogenesis, your liver's production of new glucose, which it manufactures continuously and releases into your bloodstream, particularly during fasting periods like overnight and between meals. In someone with type 2 diabetes or insulin resistance, the liver often becomes dysregulated and produces significantly more glucose than the body needs, contributing substantially to elevated fasting blood sugar. Metformin works primarily by activating an enzyme called AMP-activated protein kinase, AMPK, inside liver cells. Activated AMPK suppresses a genetic expression of the enzymes responsible for gluconeogenesis, directly reducing how much glucose your liver manufactures and releases. This is a powerful and clinically important mechanism. A landmark analysis published in the journal Diabetes Care found that metformin's primary glucose-lowering effect, accounting for the majority of its clinical benefit, came specifically through this reduction in hepatic glucose output. Metformin also has a secondary effect, modestly improving insulin sensitivity in skeletal muscle tissue through the same AMPK pathway, which helps muscle cells take up glucose from the bloodstream somewhat more efficiently. This secondary effect is real, but considerably more modest than the primary hepatic effect. Here is a critical distinction I want you to understand clearly. Metformin reduces how much glucose your liver releases. It provides a modest improvement in how efficiently your existing muscle tissue uses glucose. What it does not do is address why your insulin resistance developed and why it persists. It does not reduce visceral fat. It does not restore declining pancreatic function. It does not build the muscle mass that would dramatically improve your body's capacity to clear glucose after meals. It treats one downstream consequence of your underlying metabolic dysfunction very effectively. It does not treat the underlying dysfunction itself. Let me walk you through the 3 processes that continue driving your blood sugar elevation, regardless of metformin, because understanding each one tells you precisely what to do about it. The first process is visceral fat, the metabolically active fat that accumulates around your abdominal organs, and its direct role in driving insulin resistance throughout your body. Visceral fat is not simply inert storage tissue. It is hormonally active, releasing inflammatory cytokines including TNF-alpha and interleukin-6 directly into your circulation, and these cytokines interfere with insulin signaling in muscle, liver, and fat tissue throughout your body. The more visceral fat you carry, the more your cells resist insulin's signal to take up glucose, requiring progressively higher insulin levels to achieve the same glucose-lowering effect. Metformin does not reduce visceral fat. Some patients experience modest weight loss on metformin, generally in the range of 2 to 3 kilograms over extended use. But this is a secondary effect related to mild appetite suppression and is not metformin's primary action, and it is considerably smaller than what targeted visceral fat reduction strategies can achieve. As I explained in detail in a previous video on this channel about belly fat after 40, visceral fat responds specifically to resistance training, high-intensity interval training in brief sessions, and adequate protein intake, not to chronic cardio, and not to medication targeting hepatic glucose production. If your visceral fat has not changed since starting metformin, the insulin resistance it is driving has very likely not changed either, regardless of what your liver is doing. The second process is a progressive decline in pancreatic beta cell function. That occurs in type 2 diabetes independent of medication. Type 2 diabetes is not simply a condition of insulin resistance. It involves a gradual decline in the capacity of the beta cells in your pancreas to produce sufficient insulin to overcome that resistance. Research published in the United Kingdom Prospective Diabetes Study, one of the most influential long-term diabetes studies ever conducted, found that beta cell function continues to decline progressively over time in type 2 diabetes, regardless of which oral medication is used, including metformin. Metformin does not restore beta cell function. It does not protect beta cells from this progressive decline in any way. That has been clearly demonstrated. What it does is reduce the glucose burden that the liver places on the system, which indirectly reduces some of the demand on already strained beta cells. But this is an indirect and partial protection at best. This matters because the glucose spikes you experience after meals, particularly meals high in refined carbohydrates, place acute additional demand on beta cells that are already working at reduced capacity. Each significant glucose spike requires a corresponding insulin surge, and chronically repeated surges are believed to contribute to further beta cell stress over time, a phenomenon researchers call glucotoxicity. Reducing the frequency and severity of these post-meal spikes through specific behavioral interventions, which I will describe shortly, is one of the few accessible ways to potentially slow this decline. And metformin alone does not achieve this to nearly the same degree that meal timing and composition strategies can. The third process is skeletal muscle insulin sensitivity and glucose disposal capacity. Essentially, how efficiently your muscles can pull glucose out of your bloodstream after you eat. Muscle tissue is responsible for the majority of glucose disposal in your body following a meal. The more muscle mass you have and the more insulin sensitive that muscle tissue is, the more effectively your body clears glucose from circulation after eating, reducing both the peak of your post-meal glucose spike and how long elevated glucose persists in your bloodstream. Metformin's effect on muscle insulin sensitivity, as I mentioned, is real but modest. It does not build muscle mass. It does not replicate the dramatic improvement in muscle glucose uptake that comes from resistance training, which I discussed in detail in my video on belly fat after 40. Research published in the journal Diabetes Care found that 12 weeks of resistance training in patients with type 2 diabetes produced significant improvements in insulin sensitivity and glycemic control that were additive to, not replaced by, their existing metformin treatment. The patients who combined both interventions saw considerably better outcomes than metformin alone could achieve. So let us bring this together into exactly what you can do, starting now, alongside your metformin, to address the three processes your medication is not designed to target. For visceral fat and the inflammatory insulin resistance it drives, the evidence-based approach is the same framework I detailed in my belly fat after 40 video. Resistance training 2 to 3 times weekly, targeting major muscle groups, is the single most effective intervention for visceral fat reduction independent of weight change. Brief high-intensity interval sessions, 15 to 20 minutes, 2 to 3 times weekly, produce significant post-exercise metabolic elevation that steady cardio does not achieve. And daily walking, particularly after meals, supports the insulin-independent glucose uptake pathway in muscle. That directly reduces post-meal glucose spikes. This last point deserves emphasis, because it connects directly to content I covered into previous videos on this channel. Walking after meals activates glucose uptake in your leg muscles through a pathway that does not depend on insulin signaling at all. Your contracting muscles pull glucose directly from your bloodstream regardless of how insulin-resistant your tissue has become. A study published in Diabetes Care, which I referenced in my video about bedtime drinks and blood sugar, found that 3 15-minute walks taken after meals reduced 24-hour blood glucose more effectively than a single 45-minute walk taken at another time of day. For someone on metformin whose post-meal glucose spikes remain elevated, a consistent post-meal walking habit is one of the most powerful, completely free additions available, working through a mechanism entirely independent of your medication. For protecting remaining beta cell function, the priority is reducing the frequency and severity of post-meal glucose spikes through meal composition and sequencing, eating protein and fiber before carbohydrates within a meal. A strategy sometimes called food order has been shown in multiple studies to significantly flatten post-meal glucose curves compared to eating the same foods in a different order. A study published in Diabetes Care found that eating vegetables and protein before carbohydrates reduced post-meal glucose spikes by approximately 29% compared to eating carbohydrates first. In patients with type 2 diabetes, this costs nothing, requires no new food purchases, and simply involves reordering what is already on your plate, reducing the glucotoxic burden on your beta cells through this single behavioral change. Applied at every meal is a meaningful contribution to preserving the pancreatic function you currently have. For skeletal muscle insulin sensitivity specifically, the resistance training I described above is a primary lever, but adequate dietary protein matters significantly as well. Research suggests that adults managing type 2 diabetes benefit from protein intake in the range of 1.2 to 1.6 grams per kilogram of body weight daily to support the muscle protein synthesis that resistance training stimulates. Without adequate protein, the muscle building stimulus from exercise is significantly blunted, which limits the improvement in glucose disposal capacity that muscle growth would otherwise provide. I want to address directly what many people watching this are wondering. If you do all of these things consistently, the resistance training, the post-meal walking, the food order strategy, the adequate protein, does this mean you can stop taking metformin? The answer, as with blood pressure medication in a previous video on this channel, is that this decision belongs entirely to you and your doctor, based on your specific numbers tracked over time. What I can tell you from clinical experience and from the research is that patients who combine metformin with these specific interventions consistently achieve significantly better glycemic control than metformin alone provides, and in some cases, with sustained effort and close medical monitoring, this can create the conditions under which a doctor may consider adjusting treatment. This is never a decision to make unilaterally, and it requires patience, consistency, and partnership with your physician. What I want you to understand clearly by the end of this video is this: metformin is doing an important job, reducing the excess glucose your liver produces and providing a modest improvement in muscle insulin sensitivity. It is not designed to reduce your visceral fat, protect your beta cell function from progressive decline, or substantially improve your muscle's capacity to clear glucose after meals. Those three processes are exactly what have been driving your plateau, and they are exactly what the interventions I have described are designed to address. Your medication and these lifestyle changes are not alternatives to each other. They are to have a complete approach, working on different parts of the same underlying problem. I want to hear from you in the comments. How long have you been taking metformin, and where do your numbers currently stand relative to where you and your doctor want them to be? Your answer will help me understand exactly what to cover in more depth in future videos, and it may help someone else reading the comments recognize that their plateau has a real explanation and a real path forward. If this video gave you a clearer understanding of your treatment than you had before, please share it with someone in your life managing type 2 diabetes who has been wondering the same thing you may have been wondering. And if you have not yet subscribed to this channel, please do that now. We are building a complete, connected, evidence-based understanding of how your body's systems work together with the treatments you have been prescribed, because understanding completely is how you make the best decisions for your long-term health. I am Dr. Monroe. Your metformin is doing its part. Now you know exactly how to do yours.